Hello, so I'm back with part two of our lecture. So if you grab your PowerPoints, we had talked about pain assessment for acute pain using the 0 to 10 scale, for chronic pain using questions such as how is your pain affecting your activities of daily living, or how does your chronic pain affect your current hobbies. So other things that are used, a pain thermometer. I have not used this at any of the facilities where I've worked, but essentially, as the patient's pain increases, the pain is higher, like a higher temperature. As for pain quality, um, with neuropathic pain, typically, as you know, it's described as burning, numbing, shooting, stabbing, or an itchy sensation. Nociceptive pain is described as sharp, aching, throbbing, or cramping as well. Associated symptoms can worsen pain. Um, One of the biggest associated symptoms that you see is fatigue. Patients who are in an increased amount of pain are very tired. Also, too, fatigue can be from poor interrupted sleep during the night, as well as anxiety and depression. And of course, the SRNIs are helpful for the pain. So for strategies, pain management, try to inquire as to what's effective versus ineffective. Strategies, prescription, non-prescription drugs, non-drug therapies, typically hot and cold applications. Typically, if someone pulls a muscle, mild heat is good, maybe a heating pad, 20 minutes 4 times a day. Although for a sprain or a strain, of course, using a cold application is more effective because it brings down the swelling. But there are people, sometimes if you do have an injury, cold can cause more pain at times, and then typically I would tell patients to switch to heat for a short amount of time and see if that makes the area less painful. Other things that are used now, acupuncture, and relaxation strategies such as imagery. So documentation, as I mentioned earlier, you always need to document the effectiveness of pain medication, but just not pain medication itself. As you recall, any PRN medication that you give, whether maybe you're given Tessalon pearls for a cough, Pyridium, if someone has a UTI, you need to make sure that you evaluate that as well. For reassessment, it's critical to reassess at appropriate intervals the severity. Also, too, you need to be aware of risk of adverse effects. So, such as if you're using morphine, a lot of patients will complain of itching or pruritus after receiving the medication. And also, too, always remember to use both drug and non-drug therapies as well. And addressing pain using a professional manner. Of course, just always remember that, chronic pain, sometimes people can be judgmental, and you may think this person's not in pain, but I can tell you, I've taken care of numerous patients where, I hear nurses say, oh, there's nothing wrong with them, when indeed it turns out there was cases where, we had to send patients to tertiary centers, and we'd hear back from our care management that they have found something that we did not. Evaluating the effectiveness of all therapies to ensure that they are meeting the patient's goals. Other pain medication you might be giving, if it's causing nausea, maybe perhaps Phenergan in the hospital, somebody's receiving Demerol for acute pain from a surgery. So there's 3 categories of meds: non-opioid, opioid, which is more for moderate to severe pain, and then adjuvant therapy. So with non-opioids, it's considered acetaminophen, aspirin, and NSAIDs, and an analgesic ceiling. This is increasing the dose beyond the upper limit, provides no greater effect. So just be aware the patient can be reaching an analgesic ceiling. So non-opioids, it's a safe choice because these are less addictive. And of course, typically non-opioids are over the counter, and they can be used in conjunction with opioids because they allow for effective pain relief with lower opioid doses. So, in discussion for the non-opioids, so aspirin and other salicylates, discontinue aspirin if the patient complains of tinnitus. Remember, that is possible aspirin toxicity. Acetaminophen, that's an analgesic as well as an antipyretic effect. So acetaminophen is the best first choice medication. The principle of start low, go slow is used to guide therapy when treating older adults because the ability to metabolize medications is decreased and the likelihood of medication interactions is increased. So non-opioid analgesics are used first for mild to moderate pain, although opioids may be used later. Aspirin and NSAID drugs are associated with a high incidence, as you well know, with GI bleeding in older adults. Acetaminophen, it's available for administration by parenteral route. So IV route, the drug is spelled OFIRMEV. It's administered over 15 minutes. I've never given this drug before. IV acetaminophen, it's used to treat acute mild to moderate pain and moderate to severe pain as an adjunct to opioid analgesics or part of a multimodal analgesic regimen. And of course, the maximum dose should not exceed 4 grams per day. So with acetaminophen, there is no anti-inflammatory effects or antiplatelet therapy. So you want to avoid acetaminophen if the patient has chronic hepatitis, liver disease, cirrhosis, or they're an alcoholic. So with NSAIDs, you want to avoid in heart failure, severe heart disease. Patient can be a higher risk for an MI. GI bleeding or severe renal disease, as well as hypertension. So with long-term use, remember a proton pump inhibitor should be ordered. It's increased risk of bleeding if this is combined with a patient who's taken warfarin or Coumadin. So with our opioids, they bind to receptors in the CNS. It inhibits the transmission of nociceptive input. It alters limbic activity. So opioids are categorized according to their physiologic action. So an example, agonist and antagonist. And binding at specific opioid receptors such as your mu, your kappa, or the delta. So the most commonly administered subclass of opioids is opioid pure agonist, or morphine-like opioids, and these bind to the mu receptors. So pure agonists bind to mu receptors. So that would be your morphine, the oxycodone, as well as codeine. It's potent. There is no analgesic ceiling, and it has several routes for administration. Morphine, of course, you have to be cautious with this because it can cause respiratory depression. So you may see some drowsiness in your patients, or pupil constriction, also is referred to as meiosis. So overdose with alcohol, that can cause some respiratory depression as well. So if you recall, the antidote to morphine is Narcan because it reverses those effects. And just a reminder, so once during my career, when I was working on the floor, there was a nurse and she gave the patient some pain medication, so she thought. So the patient, she asked the patient, what have you been taking for pain? And he said, oh, I got something IV. So here she gave the patient IV Versed. And of course, Versed, typically that's given prior to a patient goes into surgery or conscious sedation. So always know what medication you're giving to the patient. And if you don't know what it is, then make sure that you are looking it up. So there's also combined with non-opioids for moderate pain, codeine plus acetaminophen, Tylenol 3, hydrocodone plus acetaminophen or ibuprofen, known as Vicoprofen. Methadone, it's a unique mu opioid receptor agonist. Typically, it's used for chronic pain. It's believed to produce analgesic effects. It's independent of its action as an opioid. So some examples of mixed agonist-antagonist. One that you may have heard of, Nubain or Tauin. These have less respiratory depression. They do have an analgesic ceiling and can precipitate withdrawal if used in a patient who is physically dependent on mu agonist drugs. So with dual mechanism agents, Ultram, so that's a weak mu agonist, and it also inhibits the reuptake of norepinephrine as well as serotonin. It is effective in low back pain, osteoarthritis, diabetic neuropathic pain, as well as postherpetic neuralgia. Tapentadol. This is approved for management of moderate to severe acute pain, for chronic moderate to severe pain. Side effects, there's less nausea and constipation as with other opioids. So, two common side effects, obviously, opioids, they cause constipation. That is the most common side effect. So if you are taking care of, older patients, you should expect them to be on perhaps maybe a stool softener, some lactulose, and they typically are on these, twice a day to a daily basis. Excuse me. Other side effects, the nausea, vomiting, respiratory depression, that's a severe side effect. So opioid-induced respiratory depression. This is typically higher in hospitalization or hospitalized patients who are treated for acute pain. Patients most at risk for respiratory depression include your elderly patients, having an underlying lung disease, sleep apnea as well. You need to be careful administering the opioid medications to them. Also, sometimes if you're working in the hospital setting, you may notice if the healthcare provider writes a scale, such as Demerol, 25 to 50 milligrams IV every 4 hours is needed. Always start with the lowest dose first and see how the patient does with that medication. If that dose was not effective, then I would go ahead and give the 50 the next time it's due. So with adjuvant therapy, with corticosteroids, this is typically used for acute and chronic cancer pain. It can be due to pain secondary to a spinal cord compression and inflammatory joint pain syndromes. Side effects, Cushing syndrome or disease, we went over that. Osteoporosis, they do cause immunosuppression, so the patient's at risk for an infection. Skin changes, such as stry, acne, and they also cause hyperglycemia as well as fluid retention. Antidepressants, so the tricyclic antidepressants or your TCAs, these enhance the descending inhibitory system by preventing cellular uptake of serotonin and norepinephrine. Caring for a patient who has diabetes and complains of chronic burning leg pain even when taking oxycodone twice daily. This works great for neuropathic pain. It's also used for post-herpetic neuralgia. So avoid high risk for suicide because these patients may hoard their pills and they could possibly overdose. Anti-seizure drugs, they affect the peripheral nerves and the CNS in several ways, including the sodium channel modulation and the central calcium channel modulation as well. Now, an example of this would be your gabapentin or Neurontin. GABA receptor agonist, baclofen. This can interfere with the transmission of nociceptive impulses. It's used for muscle spasms as well as neuropathic pain. It does cross the blood-brain barrier poorly and is much more effective for spasticity. Sorry, my allergies are bothering me. Alpha-2 adrenergic agonist, so clonidine or Catapress would be an example of this, as well as Xanaflex. So they're thought to work on the central inhibitory alpha adrenergic receptors, and they also can decrease norepinephrine release peripherally. They're used for chronic headaches as well as neuropathic pain. Local anesthetics such as Naropin can be administered epidurally by continuous infusion, but also by intermittent or continuous infusion with renal nerve blocks. And of course, when we're talking about epidurals, always remember the patient may need to be straight cath if they don't have a Foley catheter in. Cannabinoids, such as Marinol, they have been approved for medical use. Smoking marijuana or cannabis rapidly increases the plasma levels of THC, but the increase is dependent on the composition of marijuana cigarettes and inhalation technique. So this form of use is associated with variable pain relief. I'm going to skip over the audience response question. So with administration, with titration, I gave the example of the Demerol, the 25 to 50 milligrams. Again, always make sure that you start with the lowest dose of medication. Be aware patients may have side effects to drugs. So with the oral route, this is the route of choice if the patient does have a functioning GI system. Doses are larger due to the first pass effect. So this means that the oral opioids are absorbed from the GI tract into portal circulation and shunted to the liver. So partial metabolism in the liver occurs before the drug enters systemic circulation and becomes available. Transmucosal and buccal, these are often used to treat breakthrough pain. So an example of this would be a fentanyl lozenge. Intranasal routes, delivery to the vascular mucosa. This avoids that first pass effect. So an example of this would be Stadol, which is indicated for an acute headache. A nasal spray form, such as fentanyl, is also available. I haven't seen that used. Rectal, this is useful in patients who are complaining of nausea or vomiting. And actually, rectal is used quite frequently in hospice patients. You could give Roxanol, which is liquid morphine, sublingual by mouth, but you can also give rectal hydromorphone as well. Transdermal. This type of delivery system is useful for the patient who cannot tolerate oral analgesic drugs. So absorption from the patch is slow, takes about 12 to 17 hours to reach full effect. Therefore, it's not suitable for rapid dose titration, but it can be effective if the patient's pain is stable and the dose required to control it is known. So patches may need to be changed every 48 hours rather than the recommended 72 hours. Duragesic patch, that's one that's most common. The parental routes, IM, sub-Q, IV. So obviously IV is the quickest on